For the final case study, we're going to look at suicide risk in the hospital. The case review includes a 37-year-old woman with a past history of depression, anxiety, and post-traumatic stress disorder who presented to the emergency room after a suicide attempt. She overdosed on 3 to 4 tabs of alprazolam, which is a sedative, and gabapentin, which is a pain medication. She then cut both of her forearms with a kitchen knife. When she presented to the emergency room, the patient endorsed active suicidality. She had no previous attempts. Her physical exam was significant for a tearful, depressed affect and superficial lacerations to the bilateral forearms, including a 3-centimeter laceration on her left forearm. The patient's left forearm laceration was sutured and bandaged with gauze padding. The patient was observed for a period of time post-ingestion and evaluated by a psychiatrist who then placed the patient on an involuntary legal hold due to the high risk of self-harm. She was then transferred to the inpatient psych unit in the hospital. Upon arriving to the unit, she asked to use the bathroom. At that time, she unwrapped the gauze bandage from her wrist, wrapped it around her neck, and put it over the shower bar in the bathroom and attempted to hang herself. At that point, a staff member heard a noise from the bathroom, immediately entered the room, cut the gauze before the patient was seriously injured. She was then transferred back to the emergency room for further examination, where she was found to have superficial abrasions to her neck and an otherwise normal physical exam. A CT scan of the head and cervical spine were obtained, which were normal, and she ultimately readmitted to the inpatient psychiatric unit for treatment for her depression and suicidality. According to the Center for Disease Control and Prevention, suicide is the 10th leading cause of death in the United States, resulting in deaths of more than 42,500 people in 2014. They estimate that in 2013, 9.3 million adults had some form of suicidal ideation, 2.7 million formulated a plan, and 1.3 million attempted suicide. Additionally, 494,169 people were treated for self-harm in the emergency rooms. The American Psychiatric Association reported in 2003 that approximately 1,500 completed suicides take place in an inpatient setting in the U.S., and despite efforts, 1/3 of these occur while the patient is being observed on Q 15-minute checks. Many of the country's top sentinel events are mental health related, which include restraint-related events, elopements, self-inflicted injuries, and suicides. Of these top sentinel events, the settings include psychiatric hospitals, psych units within hospitals, and behavioral health facilities, and that totals 19% of all locations for sentinel events since 2004. In looking at this case, the patient had several risk factors, which included an affective disorder, depressive symptoms, and most importantly, a recent serious suicide attempt that she was being treated for. According to the case, patients who are not well known to the inpatient staff and have this cluster of symptoms should be placed on one-to-one observation until a thorough evaluation can be completed and the patient's mood stabilized. Additionally, the treatment of the arm where she had the lacerations was appropriate. However, because she is high risk for self-harm and had a previous suicide attempt, a different type of bandage or gauze covering should be considered instead of the one that they did use, as this can be a safety risk. As described in the case, she used it to attempt to hang herself. Additionally, within the case, there was a lack of documentation of what the observation status is, and it's not clear that that information was communicated from the emergency room to the inpatient psychiatric unit staff. Additionally, there needs to be staff trainings regarding suicide risk assessments and Q checks for safety. There was a lack of evaluation on the unit before letting the patient use the restroom unattended, and there were multiple ligature risks on the unit, specifically in the bathroom where the patient attempted to hang herself. The current process for treating patients with suicidal ideations and or attempts in the emergency room based on the case is when the patient arrives, they're assessed by both medical staff in the emergency room as well as a psychiatric staff member. If there are wounds, those are treated, and once the psychiatric evaluation is done, the patient is placed on observation, in this case for several hours post-ingestion. Once the patient was evaluated by a psychiatrist, they were placed on an involuntary legal hold and transferred to the inpatient psychiatric unit. At no point did they document what the Q checks were for the patient. They also did not provide any safety precautions. In this case, because the patient was such a high risk, they could have provided a safety precaution not to have any linens if she's high risk for suicide, bandages, anything of that sort that they can use to attempt to hang themselves or further hurt themselves on the unit. There are a few goals that we could implement to improve the current process. One, of course, is to increase patient safety. Additionally, we want to improve the patient experience. There need to be clear processes and communications between transferring of units, and clear and efficient processes to prevent future events. In looking at the process, there were a few steps that appear to have been missed. A new process may look as follows. A medical evaluation and treatment for any medical issues upon arrival to the emergency room will be done, followed immediately by a psychiatric evaluation in a case of self-harm or a suicide attempt, at which point they can either look at putting the patient on an involuntary legal hold or transfer to an inpatient psychiatric unit. If they are transferring the patient to an inpatient psychiatric unit, the provider should give orders for Q checks or a one-on-one observation for an initial period of time during their evaluation and implement safety precautions. Additionally, nursing and or support staff need to continue to observe the patient while on the unit based on the provider's orders, whether that be one-on-one for a certain amount of time or Q 15-minute checks, as well as any restrictions such as linens, gauze, etc. Once this process is completed and they transfer to an inpatient psychiatric unit, the nurse-to-nurse report needs to include any safety precautions the provider ordered, and those need to continue on the new unit or the new facility that the patient is transferring to. At that point, staff need to prep the unit based on the safety precautions and follow the Q checks until discontinued by a provider. So what's the solve for avoiding sentinel events due to suicide in a facility? Using the Lean Six Sigma analysis, we first have to define what the problem is, and that is that we need to eliminate sentinel events with suicide risk patients transferring from the emergency room to inpatient psych units. We measure that by reviewing the current process and identify areas of risk for the patient and facility. Then we analyze that information. Where is the greatest risk present and how can this be eliminated? And then to improve, we implement new processes based on the analysis and review on a regular basis to continue to improve based on the data provided to us. Analyzing the case and providing recommendations, the main areas of concern appear to be a lack of documentation and communication between the emergency department and the transfer to the inpatient psychiatric unit. Additionally, we need to implement and follow through on the processes and orders given by the provider. We also need to standardize suicide risk precautions between the two departments so there's continuity of care for the patient and guidelines for the staff to follow. Recommendations I would provide in this case are to provide and give continued training for all staff regarding suicide risk and prevention and how to screen and properly assess these patients. This can be done by a psychiatric provider, a licensed clinical social worker, or another mental health provider that is trained and appropriate to speak on these processes. Additionally, we need to standardize the screenings and protocols between the departments because there was a lack of communication between the emergency room and the transfer to the inpatient psychiatric unit. I would also have quarterly review of the policies and review any cases regarding suicide risk and any events that happened in the emergency room and or the inpatient psychiatric unit. I would also implement monthly environmental safety checks and remove any ligature risks within the behavioral health holding unit that may be in the emergency room and the inpatient psychiatric unit. Lastly, I would improve screening, risk assessments, safety, treatment and discharge plans, and follow-up care recommendations for all at-risk individuals. As we know, mental health, specifically in Nevada and ultimately throughout the United States, mental health treatment is not readily available for our patients, and it's ultimately doing a disservice and causing a lot of stress in the emergency department. So having services available to everybody is the forefront of the problem and needs to be addressed.